Kita saja kalau ada orang mau nanya, dok saya kira-kira bisa stroke apa enggak? Biasanya kita dengan otomatis akan jawab dengan tanda pendek, ya bisa sih gitu, cek up aja gitu. Terus begitu check up, hasilnya tunjukkan ke kita dan hasilnya ternyata dia normal, biasanya pakai oh ini udah normal, udah cukup. Pokoknya kalau asal jaga olahraga, jaga makanan dan sebagainya, dan pasien keluar dari tempat praktek kita. Selesai, hanya sampai di situ. Padahal seharusnya kita mulai bisa memberikan pelajaran pada pasien. Saat ini Anda normal misalnya, tetapi kalau Anda tidak menjaga ini, Anda akan berisiko untuk menjadi tidak normal. Begitu Anda tidak normal, mungkin butuh waktu 3 atau 6 bulan lagi, usia Anda bertambah, kemudian faktor kolesterolnya jadi tambah tidak normal, Anda akan punya risiko lebih tinggi lagi untuk jadi stroke. Jadi itu tidak sama. Nah, kadang-kadang kita sendiri yang mungkin tidak menekankan hal tersebut. Nah, memang khusus untuk penyakit atrial fibrilasi dengan stroke emboli ini paling susah itu tadi, karena memang pasien tidak merasakan. Nah, makanya kalau kita sudah waktunya untuk mulai mendorong penggunaan teknologi. Ya, kalau hanya ngandalin pasien merasakan gejala, saya juga penderita AF, tapi saya juga pertamanya juga nggak merasa. Ya, kadang-kadang kalau apalagi dulu waktu PPDS ya, mau ujian gitu kan rasanya berdebar-debar takut. Ya, saya pikir saya ujian karena berdebar-debar takut. Ternyata enggak, itu jangan-jangan sudah AF juga gitu, cuman kita nggak merasa. Nah, marilah kita mulai dorong pada pasien untuk mulai aware. Nah, salah satunya dengan memanfaatkan teknologi yang ada. Itu menjadi salah satu kunci kita sebetulnya. Kadang-kadang saya suka nyindir pasien saya. Anda pakai handphone Samsung Galaxy S24 misalnya, harganya 20 juta. Anda pakai iPhone, harganya 25 juta. Anda pakai Apple Watch, harganya 9 juta. Saya bukan penjual toko mohon maaf. Jadi karena sering diskusi sama pasien, beli Galaxy Watch 8 juta. Cuman buat Instagram, cuman buat WA, ya. Ayo dong, Anda bisa pakai itu. Ya, Anda pakai, kita lihat. Sempatkan aja bangun tidur ECG, mau tinggal masang smartwatch-nya. Ya, nah, dari situ kalau kita mulai membiasakan Anda bangun tidur, kemudian Anda pas olahraga atau pas lagi aktivitas Anda ECG paling enggak sehari 3 kali. Walaupun ECG tersebut bukan berarti menggantikan ECG konvensional 12 lead karena memang ada keterbatasannya. Tapi paling enggak itu akan membangkitkan awareness buat si pasien. Ya. Nah, tapi lepas dari apakah dia pakai teknologi atau enggak, tapi awareness-nya dia bahwa dia harus dimonitor, itu yang harus kita kembangkan. Dan susahnya lagi saat ini, karena ini pertanyaan yang umum, mohon maaf. Begitu kita ngomong, saya pernah presentasi masalah deteksi pakai genetik dan mempergunakan teknologi. Pertanyaan yang muncul selalu nomor 1 paling banyak adalah BPJS nanggung enggak? Ya bisa dimengerti, apalagi menurut data BPJS 92% rakyat Indonesia itu sudah tercover BPJS. Jadi pasti BPJS itu harus mau tidak mau harus kita dengarkan. Tapi kalau buat saya sebetulnya, ya itu kan memang kuratif. Preventif itu kan tidak selalu harus bermakna sebagai suatu pengobatan. Yang tinggal bagaimana kita melakukan awareness. Tadi pagi barusan saya diingatkan salah satu staff ya, dia ditanya tetangganya, bapak saya atau mungkin suaminya habis kena stroke, ada enggak? Ya, ada enggak kelompok komunitas penderita yang survivor stroke? Ya, saya baru ingat, iya ya. Kita udah meriksa macam-macam, udah membantu macam-macam, tapi menggarap masyarakat mereka yang habis kena stroke aja kita nggak sempat. Ya, nah itu juga salah satu cara tanpa harus pakai teknologi yang mahal untuk membangkitkan awareness. Ya, kemudian juga akan membantu mengarahkan masyarakat untuk bisa sadar terhadap kondisi kesehatannya pribadi. Jadi saya kira itu memang tantangan kita semua di sini. Jadi kalau dikatakan ada AI, terus kemudian karena saya pernah jadi ketua kolegium dan saat ini saya juga bertugas di MKKI. Salah satu yang petugas paling banyak MKKI itu apa sih? Nangani rebutan kompetensi antar masing-masing spesialis. Itu mau pekerjaan dari tahun berapa sampai tahun berapa nggak berubah-ubah. Padahal menurut saya ngapain sih rebutan? Ada ladang yang sangat luas sekali yang belum kita garap. Tapi kita hanya fokus pada satu aspek saja sehingga akhirnya malah rebutan. Nah, ini juga menjadi momentum kita untuk ini tantangan ini stroke emboli karena atrial fibrilasi ini ya, karena memang nggak usah kita dokter jantungnya aja kadang-kadang nggak bisa mendiagnosa karena memang tidak ketemu saat yang tepat, apalagi kalau pasiennya paroksismalnya sangat menonjol. Saya kira itu mungkin ya, Dr. Rodi. Terima kasih.
Baik, terima kasih. Apakah ada pertanyaan dari peserta? Silakan, dokter yang di sana dulu. mohon perkenalkan diri dan menyampaikan untuk siapa.
Ya. Selamat pagi dokter. Izin saya Dwi Agustina, dokter umum. Izin bertanya dok, seperti yang tadi dijelaskan bahwa AF yang tidak ada keluhan, kadang ke dokter jantung aja tidak diberikan obat dok. Nah, pada saat kapan kita memberikan terapi preventif yang memang pasien tersebut ternyata AF-nya normal gitu, AF tanpa keluhan. Dia setiap kali di EKG menemukan AF tapi tidak bergejala apapun. Saat kapan kita konsulkan dia ke kardio, saat kapan kita konsulkan pasien tersebut ke neuro, dan kapan kita memberikan obat preventif tersebut dan sampai berapa lama apixaban itu bisa diberikan. Mohon izin dokter, terima kasih.
Baik, untuk monggo Dr. Valen, nanti Dr. Eko akan menambahkan.
Ya, terima kasih dok atas pertanyaannya. Jadi untuk AF walaupun nggak ada bergejala, tapi begitu seseorang sudah dideteksi dengan atrial fibrilasi, mungkin para dokter bisa menggunakan skor CHA2 DS2 fast score, CHA2 fast score dok. Nah dari situ nggak perlu dihafal dok, di website, kemudian di Play Store, kemudian di Apple dan lain-lain ada programnya, langsung tinggal masukkan kondisi pasien tadi. Ketika nilainya tadi lebih dari sama dengan 2 untuk pria, dan lebih dari sama dengan 3 untuk wanita, maka sudah mulai indikasi untuk pemberian oral antikoagulan. Kemudian dirujuk juga untuk ke kardio juga untuk melihat katupnya tadi dok, memang ada mitral stenosis moderate to severe atau tidak, dan memang ada pengguna katup jantung mekanik tidak. Jika tidak, maka termasuk AF non valvular. Itu terapinya bisa dengan direct oral antikoagulan dengan apixaban dengan sejumlah keunggulannya tadi. Tapi jika memang tetap moderate to severe mitral stenosis atau katup jantung mekanik, maka tentunya dianggap AF valvular, terapinya tetap warfarin dok. Nah untuk selama durasi pemberiannya juga harus kolaborasi dengan dokter jantung juga dan melihat juga apakah AF-nya akan ada tindakan seperti misalnya ablasi kardiak atau tidak, atau memang keputusan dari dokter jantung dan dari keluarga AF-nya kita terapi dengan preventif dan dengan terapi medikamentosa. Jadi seperti itu. Dan tentunya tadi juga pemilihan obat dan efek samping dan risiko perdarahan juga kita pantau. Untuk risiko perdarahan mungkin dokter juga bisa menggunakan skor Hasbled tadi. Dan untuk durasinya jangka panjang, kecuali AF-nya nanti bisa di normal versikan jadi irama sinus oleh tindakan dari kardio. Mungkin seperti itu jawaban saya. Mungkin dokter Eko mau menambahkan?
Ya, jadi setuju. Jadi kenapa tadi di salah satu slide saya tampilkan kan, ada seseorang yang melakukan hampir 1000 ECG dari dalam waktu 1 tahun dari Apple Watch-nya dia, kita bisa melihat distribusinya kan, berapa persen dia jadi AF dan lain sebagainya. Jadi prinsipnya begini, ya pokoknya begitu AF Anda jangan ragu-ragu untuk ngobati. Ingat, yang kita pertaruhkan adalah begitu dia jadi CVA, quality of life-nya dia. Ya, quality of life-nya dia. Bayangkan umur 50, jangan 55, saya pas 55 soalnya kok nggak enak mau ngomong umur 55 ya. Bayangkan umur 60 kemudian kena stroke, sementara ternyata dalam tanda petik takdirnya seseorang ini adalah sampai umur 85 tahun, 15 tahun dalam kondisi stroke. Itu yang stroke akhirnya keluarganya juga. Ya, jadi itu yang kita pertaruhkan. Jadi memang prinsipnya begitu kita meyakini secara klinis setelah berpikir secara evidence, berpikir secara sebagai seorang dokter yang benar, kita menganggap oke, ini memang AF, ya udah kita memang harus melakukan terapi sampai faktor penyebab atau faktor risikonya memang betul-betul tertangani. Jadi ya saya ngomong ke jantung, misalnya ini tadi sampaikan dokter tadi ya, jadi oke, saya ngomong, Anda begitu ngomong ini jantungnya sudah aman, stop aja antikoagulan, boleh, enggak masalah. Tapi begitu kita yakin bahwa enggak, ini pasiennya masih suka muncul, ya udah jangan coba-coba untuk tidak melakukan treatment secara tepat. Tapi saya juga harus mengingatkan loh ya, seperti yang disampaikan oleh guru saya Dr. Hari Purnomo, bahwa kita ngobati manusia, bukan ngobati penyakit. Ingat bahwa tidak hanya obat, tetapi faktor-faktor risiko pemberat terjadinya AF pun kita juga harus ingat ya. Contohnya saya ketemu beberapa PPDS saya, mantan PPDS saya yang sekarang jadi neurolog top semua ya, yang berat badannya berubah ya. Nah, saya harus ingetin yang berat badannya siapa tadi? Asar, mana Asar? Ya, hati-hati. Berat badan naik itu juga salah satu faktor risiko untuk jadi atrial fibrilasi yang akan sulit terkontrol. Belum suka ngopi lagi ya. Nah, Jangan lupa itu juga harus dikendalikan. Kalaupun kita belum bisa melakukan terapi, tapi itu harus dikendalikan dulu. Ya, jadi mungkin itu ya, makanya kenapa begitu pasien itu harus dimonitor secara ketat memang, 3 bulan sekali atau 2 bulan sekali. Dan ingat itu yang harus kita sampaikan ke pasien. Jangan pasien merasa datang, misalnya nanya ke kita, kapan kontrol lagi dok? 2 bulan. Datang lagi 2 bulan lagi, kita datang, mereka datang ke kita, gimana? Tensi bagus, ini bagus, periksa sebentar, kasih resep, pulang. Enggak. Edukasi pasien ini, kenapa kok dia harus kontrol, dan edukasi apa yang akan dia lakukan dalam 2 bulan sebelum ketemu kita lagi. Nah itu tadi yang harus disampaikan. Ya, saya kira itu mungkin secara singkatnya aja. Ya, oke, terima kasih.
Baik, terima kasih. Kami mohon maaf karena waktu telah habis pada diskusi sesi ini. Mungkin sedikit yang bisa saya simpulkan, tadi sudah disampaikan bagaimana kemudian kita mengetahui indikasi dari pemilihan DOAC pada pasien-pasien dengan AF, stroke dengan AF, dan tadi yang sampai terakhir kata kuncinya tidak hanya sekedar memberikan tahu tapi juga harus memonitor. Banyak sekali yang harus dimonitor dan meningkatkan awareness dari masyarakat ini juga penting untuk mencegah terjadinya stroke pada pasien-pasien dengan atrial fibrilasi. Terima kasih, kami tutup pada sesi kedua ini. Terima kasih pada para pembicara. Saya akhiri, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang.
Terima kasih banyak saya sampaikan kepada moderator dan para pembicara, terutama kepada Dr. Valentinus. Terima kasih banyak atas pantun untuk Mielum 12 tahun ini. Hadirin sekalian, kami sampaikan juga bahwa setelah ini kita akan memasuki salah satu sesi yang sangat kita tunggu-tunggu. Namun sesi apa? Kita saksikan video berikut. Ladies and gentlemen, going to the next sections, neuroinfections. These sections will be broadcast to all medical faculties across Indonesia.
Here we are proudly present our guest speaker from Oxford University, Professor Guy Edwards, along with neuroinfection consultant Dr. Badrul Munir, specialist neurology consultant. This session will be moderated by Dr. Zamroni Afif, Specialist Neurology Consultant.
Proving outcomes from tuberculosis meningitis will be delivered by Professor Guy Edward Twice. Here is the CV. Professor Guy Edward Twice, PhD. Education and Honor Appointed Member of the Order of the British Empire, MBA, Service to Public Health and UK-Vietnam Relations in 2021. Elected a Fellow of the Academic Medical Science in the UK. Expertise qualified from the Cambridge University and the United Medical and Dental Schools of Guy and St. Thomas Hospital. Now he's occupied as the Director of the Oxford University Clinical Research and Vietnam Welcome Africa Asians Program, Professor of the Infectious Disease University of Oxford, Honor Consultants in Infectious Disease and Clinical Microbiology at the Guy and St. Thomas NHS Foundation. Here is the Professor Guy Edward Twice, PhD, MBA.
Hello everyone, my name is Guy Thwaites. I am an infectious disease doctor. I live and I work in Vietnam. I'm director of the Oxford University Clinical Research Unit, which is a large-scale clinical research unit in infectious diseases that works in Vietnam, Indonesia and Nepal. And I'm delighted to be able to give you a talk today on TB meningitis, and more specifically the question of how you improve outcomes from TB meningitis. So, just a very brief overview of OCRU, the Oxford University Clinical Research Units. We're about 550 people working across 4 units in Asia. You can see those units marked here. So we have units in Jakarta, about 120 people there, but also a major unit in Ho Chi Minh City in Vietnam, about 350 people here, about 50 in Hanoi, and about the same number in Kathmandu in Nepal. And you can see we have multiple different collaborators and research sites, and that just gives you an idea here on the right of where they are. And our vision is to have local, regional and global impact on health by leading a locally driven research program on infectious diseases. And the locally driven is really important. We address things of importance to the populations in these regions, not elsewhere. So, TBM. I'm assuming you're reasonably familiar with this nasty disease, but just as a quick overview. So it's a subacute or chronic meningitis. Symptoms occur usually over 1 to 2 weeks, possibly longer. Headache, fever, vomiting, and those symptoms progress often towards coma and focal neurological signs. And ultimately, if not treated, patients almost invariably die. It's a basal meningitis. You can see the picture in the middle here is of a post-mortem brain, and there's this sticky, nasty white exudate around the base of the brain. But it causes a number of classical problems, some hydrocephalus you can see down here, infarcts, you can see a large infarct here, and then tuberculomas, so ring-enhancing lesions on imaging, which are also common complications of this infection. So I started working on TB meningitis about 24 years ago, rather remarkably. And there were 2 papers that I went to almost immediately, and these I show you here. So on the left, as you look at the screen, a paper published in 1953 in the Journal of Clinical Pathology, which looked at the basic microbiological diagnosis of TB meningitis. And it gave some really quite remarkable results. So very simply, centrifuging it hard and doing meticulous microbiology and looking for the acid-fast bacilli, they were able to find bacteria in nearly all cases. These were in children, admittedly. This was just about the pre-chemotherapeutic era. But the critical thing is doing very good, simple microbiology well works, and I'll show you a little bit of data on that shortly. And the other paper was on the right, a paper published in the late 1990s by Johan Skuman and others in Cape Town, which was the first really to conclusively, or reasonably conclusively anyway, it's a relatively small trial, but show that corticosteroids improved outcome, and it was in childhood TBM. So one of the first things that I did when starting to work in Vietnam 24 years ago was to try and work out whether we could improve the diagnosis. And so I went back to that 1953 paper and just very simply looked at the volumes of CSF, and you can see those here, and the isolation rates from the CSF. And you can see this in very, very clear relationship between the larger volumes and much higher rates of isolation of bacteria from CSF. And these were the things that predicted bacteriology. So this was in 107 cases of adults with TB meningitis. And these are the things that predicted positive bacteriology. So duration of symptoms, the longer the symptoms, the more likely. The volume of CSF, note, strongest predictor. Neutrophils in the CSF, high lactate and low glucose. So just very simply, if you want to get basic microbiology good, you need to take large volumes of CSF for examination. But how can we improve outcomes from TB meningitis? Well, aside from better rapid diagnostic methods, which we still need, by the way, we can do a number of things. We can control the intracerebral inflammatory response, we can kill the bacteria better, and we can look after our patients better, because these are people who are critically ill and often on intensive care units. Now, one of the first things that we did at scale, anyway, was to ask the question whether dexamethasone improved the outcome of adults with TB meningitis. And this was a trial published 20 years ago now, again, rather remarkably, which showed a very clear result. So you can see the survival curve in the middle. This is all patients. This is the survival in the dexamethasone group. This is the survival in the placebo group. You can see a p-value 0.01 there. So overall, dexamethasone improved survival in 545 adults with TB meningitis. There were 98 people in this trial with HIV, relatively small number, and you can see here much less clear as to whether dexamethasone benefits these patients. The other thing you can see here, and these are the 5-year follow-up survival curves, is that actually the effect is most and persistent in those people with the least severe disease, so grade 1 disease. In fact, the effect in those with the most severe disease is relatively short-lived. And I suspect this is because dexamethasone is saving lives, but the people who survive have quite severe neurological deficit and subsequently die of other complications. So a take-home message, please, do not just reserve steroids for people who have severe disease. Their benefit is marked in those people with less severe disease. But there are other things that influence outcome aside from steroids, and the trial allowed us to look at those things. Here's a couple of papers from the trial. So this one looking at HIV infection, and you can see the catastrophically different outcomes between the HIV uninfected and the HIV infected here. And we'll come back to this in a few minutes' time. But terrible outcomes where nearly 60% of people dying by 9 months with HIV and TB meningitis. And the other thing that was very uncertain, and still remains uncertain, is the effect of drug resistance on outcome. But what isn't uncertain is the catastrophic effect of multi-drug resistant TB on outcome. So in this trial, which was done between 2000 and 2004, so before the advent of expert and the ability to rapidly diagnose multi-drug resistance, everybody died within about 60 days. And that's primarily because cultures take about 60 to 80 days, and you couldn't find out whether people had multi-drug resistance or not before they died. So that was a real problem. It's improved a little bit with experts, but not that much. The other way of improving outcomes, if you've controlled the inflammatory response, is to enhance bacterial killing. And one of the unique things about TB meningitis as opposed to other forms of TB is that there is the blood-brain barrier. And the blood-brain barrier stops, or potentially stops, drugs passing into the central nervous system and killing bacteria. Now, there are some drugs which pass very easily into the central nervous system, so isoniazid, ethionamide, pyrazinamide particularly. The fluoroquinolones are quite good at getting into the central nervous system. The newer drugs, bedaquiline probably doesn't very much, but delamidine and protonamide probably do. Rifampicin, however, has been a key drug in the treatment of TB for many years, but great uncertainty as to its benefit in TB meningitis, because only about 10% of the concentration in plasma gets through to the central nervous system. So we set about answering this, or trying to answer this question, with a large trial. So this was the largest trial ever done in TB meningitis until recently. 817 Vietnamese adults, and we randomized them to normal care or receiving higher doses of rifampicin, 15 milligrams per kilogram, and the addition of levofloxacin as a fifth drug. Now, those doses of rifampicin are not as high as have been recently trialed, but nonetheless, we showed absolutely no suggestion of benefit of higher doses of rifampicin in this trial. And when you looked at subgroups, again, by drug resistance, so on the left, you can see a terrible outcome for multi-drug resistant TB, but expert had arrived now, so we were able to detect rifampicin resistance a bit earlier. So only about 75% of people were dying, as opposed to 100%. But the interesting finding from this trial, so remember overall, that combination of 15 mg per kg of rifampicin and levofloxacin had no beneficial effect. It did have a beneficial effect on those people who had isoniazid resistant TBM. Now, whether that effect is driven by the higher doses of rifampicin or whether it's driven by the levofloxacin is unclear. However, we went on in a subset of patients in this trial to look at the concentrations of the drugs and their relationship with outcome. And the key findings were as follows. So we could find no relationship at all between rifampicin exposures, so these are the time profiles of the concentrations of the drug in CSF, and outcome, nothing at all. However, we did find strong relationships between isoniazid exposure and survival. And you can see on the right here, so these are the three columns, Glasgow Coma score 8, 10, and 14, so severe disease, less severe disease. And this is survival along this axis. And this is HIV negative, and this is HIV positive. So regardless of HIV positive or negative, so the survival in those people with the lowest doses, lowest concentrations, is much worse than those people with the highest concentrations of isoniazid. And the thing that drives those exposures within the CSF is probably metabolizers and fast and slow metabolizers of isoniazid, which is well known. And in the 38 deaths that occurred in the subset of patients in this study, 28 were fast metabolizers. The other question, though, that was arising about the same sort of time was whether aspirin might be a useful drug in the treatment of TB meningitis. And there were two previous trials, one done by Johan Schoeman, who you can see here in South Africa, and this is Usha Misra in Lucknow in India. They'd done a couple of small trials which suggested a possible benefit. So we went on to do a phase 2 trial. This wasn't large, this was 120 patients. And we compared two doses of aspirin, a low dose, which would inhibit thromboxane A2 on platelets and therefore maybe antithrombotic and anti-infarct in TB meningitis, and that might improve outcomes, or a higher dose, and we were using 1,000 milligrams a day, which has two effects. Firstly, it is anti-inflammatory, so it inhibits the production of inflammatory prostaglandins, but it also upregulates pro-resolving mediators that might decrease inflammation and improve outcome. So this is the results of the trial published in eLife in 2018. Now remember, this is again a phase 2 trial, so it's not clinically definitive, but there were some very interesting findings. And the most apparent finding was that aspirin at 1,000 milligrams was safe, so this was given with dexamethasone, and might reduce death of new infarcts. So every patient had serial MRIs in this study. And this has provoked a lot of interest, and there are a number of phase 3 trials now of aspirin going on around the world, which will conclude next year or the year after. But our intention returned to dexamethasone to answer two questions, if we possibly could. The first one was in HIV, and this is the ACT HIV trial. So very simply, is it beneficial to give dexamethasone to HIV-infected patients, as we think it is for HIV uninfected? So we randomized 520 people to that trial, and it's just been, published about 6 months ago, and I'll show you the results. And then another trial, which I can't show you the results for, I'm afraid, because we're just analyzing it, but this is, we wondered whether a particular gene that seems to confer inflammatory phenotypes within patients also confers responsiveness to steroids. So I'm not going to tell you in detail about that trial, but that trial was of 720 people where we stratified dexamethasone on the basis of that genotype. So here are results of the ACT HIV trial, so adjunctive dexamethasone for TB meningitis in HIV-positive adults, published last year. And the overall survival curves you can see here, so that there is a separation of the lines, as you can see, but this is not statistically significant. And I think that the sort of overriding conclusion of this is that there may well be a beneficial effect of dexamethasone in HIV-positive adults, but even this trial, which was 520 patients, was not large enough to be able to establish that benefit. Notably, these patients were extremely immunosuppressed. So 52% of them had CD4 counts less than 50. 50% of them had never received antiretroviral therapy. And yet, dexamethasone was safe in this group of patients. There was no excess of adverse events in these patients. So, the next, I've told you a little bit about this, but these results are coming. So this is the last ACT trial where we genotype stratified, but results on their way. The other thing I wanted to mention was the neurocritical care of TBM. Now, there's very little data, very little evidence to help us here. Very, very few randomized controlled trials, at least of the types of interventions that are usually associated with intensive care units. And this is a review we published about 3 or 4 years ago, you can see here, which summarizes the various challenges that we have and the various management uncertainties that exist. And the big one, I think, is hydrocephalus. Many people, of course, will shunt if they have it available. VP shunts are often used, particularly if they've got obstructive hydrocephalus. Hyponatremia is a really big problem, very common, but again, the management is very, very uncertain. Paradoxical reactions, so the enlargement of tuberculomas. Most people would use steroids, but there are no randomized controlled trials to demonstrate benefit. And how to actively define and support raised intracranial pressure. And I just highlight you to a couple of investigations here, which we've done in Vietnam, one using optic nerve sheath ultrasound for detecting raised ICP, and the other automated pupillometry. So these are relatively small studies, proof of principle, but both showed quite strong associations between the use of them and severity of disease and outcomes. So just on a wider note, there is a TB Meningitis International Research Consortium that's been active since about 2008. We've met around the world on various occasions, and you can see on the left there, including a COVID meeting online in 2020. But you'll be happy to hear that the next meeting is on November the 9th to the 11th in Ubud in Bali, which we're very much looking forward to. I'm afraid we're sold out on these tickets for all the spaces for this meeting, and we have about 100 people there for 2 days to discuss TB meningitis and the challenge. One of the things that we like to do, though, as a group, is to produce papers that are useful for clinicians. And this is our most recent contribution, which was published online just about 3 days ago in Lancet Infectious Diseases. 2 things that I highlight here. So first, on the right is a summary of the currently active trials in TB meningitis. And you'll note, if you can read it quick enough, but I'll show you, that many of these trials are looking at high-dose rifampicin. So, and by high dose, we mean 35 mg per kg, not the 15 mg per kg that we trialed some years ago. So we're going to know whether or not I think high-dose rifampicin is beneficial soon. We'll also know about aspirin. There's about 3 trials looking at aspirin. And there's just a start. There's one trial looking at adalimumab, which is a TNF inhibitor, which is going to be very interesting. There are, however, a number of future regimens for trials which we propose in this paper. I won't go into detail, but essentially it's pretty important, I think, that we start to look at rifampicin-free regimens and try and work out whether we can use the bedaquiline pretomanid or delamanid combinations that have been so effective for multi-drug resistant pulmonary tuberculosis. So that's all. Many people have worked on TB meningitis with me over the years and done much work. Certainly a team sport, not just mine at all. So there's the TB group in Oxford University Clinical Research Unit in both Indonesia and Vietnam. We have multiple partners and multiple collaborators for whom we're extremely grateful for the work we do together. And with that, I will close, and I look forward to joining you live when the meeting happens and answering your questions. Bye-bye.
Next lecture, Challenge in Diagnosing and Treating TB Meningitis in Developing Countries, will be delivered by Dr. Badrul Munir, Spesialis Neurologi Konsultan.
Berikut adalah CV beliau. Dr. Badrul Munir, Spesialis Neurologi Konsultan, menyelesaikan pendidikan S1 dari Fakultas Kedokteran Universitas Brawijaya Malang, menyelesaikan pendidikan dokter spesialis dari Fakultas Kedokteran Universitas Erlangga Surabaya, Doctoral Program Faculty of Medicine Brawijaya University. Beliau aktif dalam organisasi Member Department of Health Finance and National Health Insurance Perdosni, dan saat ini beliau aktif sebagai Lecturer Staff Neuroinfections, Neuroimmunology, and Neurointensive Care Divisions Department of Neurology Dr. Saiful Anwar General Hospital. Kepada Dr. Badrul Munir, Spesialis Neurologi Konsultan, kami persilahkan.
Thank you for MC, and I would like to thank you for Mr. Prof. Twice. And thank you for your willing and join this meeting, and thank you for your nice presentation. Hopefully we can get some benefit to apply the practical clinics. Now we will presentation about my topic, the challenges of diagnosis and treatment of meningitis in developing countries. Slide. As introduction, the prevalence of the tuberculosis infection in Indonesia and my country is the third highest in the world after India and China. And as we know, tuberculosis meningitis is an inflammatory process in the menial and parenchymal caused by Mycobacterium tuberculosis. The incidence of tuberculosis meningitis about 15% of all TB infection and 15% all extrapulmonary TB infection. And TBM has high mortality and morbidity, especially in developing countries like Indonesia. The high mortality caused by the difficult diagnosis and severe complication and resistant oral anti-tuberculosis. Slide. This is the epidemiological of tuberculosis meningitis. We can see the incidence of TBM in the world about 164,000 cases in adults, and mortality rate about 23 until 25% globally, and up to 67% in study from Asia like Indonesia. Slide. What about the incident tuberculosis in Indonesia? There is no data national tuberculosis in Indonesia. But based on the hospital study, we can see the Jakarta in capital city, TBM is about 50% of all infection in the neurology department of Cipto Mangunkusumo Hospital. In Bandung, West Java, TBM is about 80% of all infection in neurology Hasan Sadikin Bandung. In our city, Malang, East Java, TBM is about 44% of all CNS infection in the ward in Saiful Anwar Hospital. Slide. What about the factual tuberculosis meningitis in Indonesia? The diagnosis of tuberculosis meningitis is difficult and require high costly. The only few hospitals have facility to confirm diagnosis tuberculosis meningitis in Indonesia, and mortality rate TBM in Indonesia is higher than other country. And the high mortality rate is related to the lack of time for diagnosis and what stadium when patient initial hospital, and maybe tuberculosis drug resistant may be cause increment of mortality case. Slide. How to make diagnosis tuberculosis meningitis? Tuberculosis meningitis we could diagnosis by the clinical criteria, twice diagnosis or MRI's criteria. The clinical criteria for diagnosis are based on the combined medical history, clinical assessment, and all the relevant investigation, including chest investigation or neuroimaging. The two-way diagnosis based scoring for the diagnosis TPM in adult, in clinical and laboratory finding, and MARA is commonly used it, classification pattern, definitive, probable, possible, and not definitive, based on the composite score of clinical finding, CNF, neuroimaging, evidence-based of TB silver, and exclusion alternative diagnosis. Slide. Now we are going to the study meningitis tuberculosis in Indonesia, especially in Malang, Jawa Timur. Malang is the second biggest city in Java, and hospital and Saiful Anwar Hospital is the referral type A, top referral in area. Slide. The method study, we use the descriptive study, location study in the Logawat Saiful Anwar General Hospital, tertiary referral hospital. To recent years, the diagnosis MARA is criteria TB based on clinical, radiological, and laboratory criteria. This is our hospital, Saiful Anwar Hospital. Slide. We can see the incidence of TBM versus neuroinfection disease in Saiful Anwar Malang. The TB meningitis is the highest infection, about 44% or 130 patients, followed out by toxoplasma, encephalitis, and abscess cerebri. Slide. This is a database of tuberculosis meningitis in Saiful Anwar Malang. From the age, common patient is young patient, about 53 years old, and ratio male and female is the same, about 46 until 56%. And based on MARA's criteria, only 22% patient with definitive METP. It means we can detect TB on the LCS. The common patient, probable and possible, about 48% and 32%. Slide. This is a sign and clinical symptom, MDP or General Hospital Saiful Anwar. From the symptom, headache, fever, and light, it is the common symptom when patient arrive to hospital, to Saiful Anwar Hospital. And the crisis of consciousness, meningal sign, and hemiparesis is the common clinical symptom where patient arrive and hospitalized in Saiful Anwar Hospital, followed by the nerve cranial pulses, nerve 7, nerve 3, and nerve 4. Slide. Okay, slide. This study, another study towards 2010, and the symptom, the common symptoms are headache, fever, vomiting, and clinical sign and sickness, confusion, coma, and cranial palsy. Slide. What about the pulmonary tuberculosis and past OAT treatment? From my study appear that's the history of pulmonary tuberculosis about 46% and history of oral anti-tuberculosis treatment about 41%. Slide. This is interesting, my study, TBM or HIV patient. TBM on HIV patient in my study about 24% with high case fatality. This is the higher than the other study. The prevalent TBM in the other study was 13%, and the case fatality about 36%. The case fatality of TB, high case fatality of TB in HIV patient, all patients usually die when patient outcomes, right? This is the performance of cerebrospinal fluid examination in TBM. Culture test, we get about 7%. Can expect we found about 50%, and generation only 1%. The common of examination performance not detected anymore, about 81%. Slide. What about the ORT-resistant TB meningitis in Malang, Jawa Timur? ORT resistant lead to poor outcome to TB disease. In my study, based on gain expectation, we get rifampicin resistant was 13%, and ORT resistant related to high mortality. In my study, all patients TB resistant was die. Actually, in our hospital, no specific recommend ORT resistant for TB intracranial, and usually we use recommend all pulmonary TB to treat OAT resistant, but we don't know about effectiveness. Slide. This is the head CT scan tuberculosis meningitis. That partial meningitis enhancement in heterocephalus is the common clinical, common radiological picture in our study. And interesting, the heterocephalus is very high, and this is related with the outcome patient, when patient discharged from hospital. Usually, patient heterocephalus have bad prognosis. Slide. This is a stadium of tuberculosis meningitis in Indonesia, especially in Malang. We can see the grade 2 and grade 3 is the common greeting for our patient, about 58% and 24%. Then only 18% patient come to our hospital with grade 1. Slide. This is related with outcome tuberculosis meningitis. The high mortality, about 27%, and patient discharged on the condition life is about 73%. Slide. This is the challenge of diagnosis and management TBM in Indonesia. We can know the diagnosis and treatment TBM is difficult and high costly, and diagnosis TBM difficult for diagnosis because the clinical presence similarly the order of meningitis. It is often led to daily treatment and sequential mortality. And severe complications lead to poor outcome, and TB with HIV and TB with OAT tend to increase in Indonesia and need management, and it is need new biomarker to TB diagnosis faster in Asia in developing countries. There a new marker for TB tuberculosis. We can use a pathogen or host. The pathogen we can use antigen, RNA, and VOC, then biomarker from host. We can use a cytokine, antibody, mRNA, and other. The all new biomarker hopefully can help to make diagnosis easy and faster. Slide. One of the new biomarker potential. This is a recombinant antigen 3TX and epitope antigen recombinant CTX in the humoral animal study that use the increases of humoral immune response and potential to make diagnosis as a potential new biomarker for TB. Slide. Besides the protein, the epitope also to help to make the new marker for diagnosis meningitis, especially the epitope of the antigen recombinant. And we had two epitope dominant, and epitope dominant is very potential to make diagnosis, increases sensitivities and sensitivitas and specificitas for patient diagnosis tuberculosis. Slide. This paper I will present it in the TB International Research Consortium in Bali next month, with the Prof. Marais and another ahli. Slide. We said the protein and antigen. We also study about clinical and laboratory LDRI as particular differentiation between tuberculosis meningitis. And from this our study, we get the Brawijaya meningitis score to differentiate between TB caused by meningitis caused by TB or meningitis caused by virus. But that Brawijaya meningitis score, if Brawijaya meningitis score value more than 3 related to the TB meningitis. Slide. As conclusion, diagnosis tuberculosis meningitis is difficult and need new tool of diagnosis. Diagnosis in TBM is difficult for clinician. It is often led to delay in treatment and related with poor outcome. OAT resistant TB lead poor outcome, and TB HIV patient tend to increase, and it has clear clinical symptom and difficult diagnosis, and needs a new biomarker to TB diagnosis, and new tool diagnosis is needed to faster and easier diagnosis TB in developing country like Indonesia. This is my presentation. Hopefully we can get any benefit from medicine. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, we are still joined online by the Professor twice. To expedite our discussions, we would like to invite Dr. Zamroni Afif, Specialist Neurology Consultant and Biomed. As a moderator, here is the CV. Dr. Zamroni Afif, Spesialis Neurologi Konsultan M. Biomed RPSGT, menyelesaikan pendidikan S1 dan pendidikan dokter spesialis saraf dari Fakultas Kedokteran Universitas Brawijaya, Fellowship Sleep Medicine dari Changyong Memorial Hospital Taiwan, The Registered Polysomnographic Technologies. Dan saat ini beliau aktif sebagai Lecturer Staff Neurophysiology Epilepsy and Sleep Disorder Divisions, Department of Neurology. Kepada pembicara Dr. Badrul Munir, Profesor Twice, dan Dr. Zamroni Afif, time is yours.
Okay, thank you very much. And dear to our honorable speaker, Professor Guy Twice is already joined with us. Thank you for joining our session today, Professor. How do you do? Fine?
Yes, very well, thank you. Thank you very much for inviting me. Look forward to the questions. Can you hear me okay?
Yes, I can hear you, Prof. We have
Good.
already tried to connecting with our participant here. Okay, let's continue to our discussion. So we are open to question from all audience here. Is there any question or maybe a suggestion for all participants, please? Okay, we have already have one audience.
Good afternoon. Thank you, Professor Twice, for your insightful presentation. I have a question regarding paradoxical reaction or IRIS in patients with tuberculous meningitis. How do paradoxical reaction manifestation differ from treatment failure or disease progression? And are there any specific diagnostic tools or biomarkers that can aid in this diagnosis or differentiation? Thank you.
Yeah, thank you. That's a very good question. Quite a hard one to answer, actually. So the critical part of this question is whether or not if a patient gets symptoms after the start of treatment, whether or not it's because the antibiotics are failing or because they've got inflammatory complications. And I think you're asking how you tell those two apart. And the answer is quite tricky, really. I would say overall, the most common reason for people doing badly after the start of treatment is because of inflammation. It's not because of drug resistance or a failure of antibiotics. And I say that through experience, really. But let me give you a few thoughts on how to tell the two apart. So if you have antibiotic failure because of resistance, then generally you get a steady decline of the patient to death particularly if they've got multi-drug resistant TB, unless you change the drugs. So drug resistance tends to present with just a very steady decline of clinical symptoms. Whereas those people who develop paradoxical reactions or ARIS often get better for a period of time, and then they have problems. And those problems are usually highlighted by brain imaging. So if you do MRIs, for example, you might see enlarging tuberculomas or worsening exudates and associated infarcts. And that generally tells you that it's an inflammatory problem. So the short answer to your question is it's careful determination of the natural history of response to treatment. If people steadily get worse, then you have to think about drug resistance. But if there's a period of getting better and then getting worse, then usually that's due to inflammatory complications, not drug resistance. I hope that answers your question sufficiently.
Yes, thank you, Professor. Is it already clear, Dr. Priyo?
Clear, but can I ask more question?
Okay.
Additionally, about the role of corticosteroid about treatment strategy for iris, is there any concern for the long-term medication or corticosteroid use for this iris or paradoxical reaction? Thank you.
Well, there aren't any randomized controlled trials to show that corticosteroids are beneficial for these inflammatory complications, but nearly everybody, I think, will use them, and I think rightly so. I think most of us will have had experience of patients getting better after starting steroids for paradoxical reactions or ARIS, but the evidence, as I say, is not strong. Your question about whether or not there's any harm of steroids, well, at least in the trials that have been done looking at steroids at the beginning of treatment, there's very little evidence of harm. But of course, we all know that being on long-term steroids is harmful to patients, regardless of what people have been given steroids for. So you have the problems of diabetes, high blood pressure, other infections, and so forth. And we see a lot of those problems in people who have very persistent brain inflammation associated with TB meningitis. And the question is whether you can put them on something else other than steroids. And again, there's very little evidence to tell you what to do. But I think the two options that are generally used globally are either a drug called infliximab, so targeting TNF, or it could, of course, be andulimab, which is the trial going on at the moment. And some people, particularly in South Africa, use thalidomide. Personally, I've used both, but I don't have a lot of recent experience of using thalidomide. But it's challenging. And so again, to go back to your original question, yes, there are problems with using long-term corticosteroids, but they're the ones that everybody knows about corticosteroids. There's nothing really to suggest that they harm outcomes in any way from TB meningitis. And indeed, they must be used in certain circumstances when there's too much inflammation.
Thank you very much, Prof.
Okay, thank you, Professor, and thank you for Dr. Priyo. Is there any other question from the audience? Yeah, please, thank you.
Thank you for the opportunity. My name is Hani from Malang. I would like to ask Dr. Badrul Munir. As far as I know, in the hospital, there were so many patients drop out of the treatment. So what are the challenges in ensuring adherence to treatment regimens in developing countries, and how can we overcome it? Thank you.
Okay, thank you for nice question. Actually, in my practical in daily, we usually that's many patients drop off of oral antituberculosis when we start the treatment of meningitis tuberculosis. So how to strategy to treat it? Where patient get off the oral antituberculosis more than 2 months and we get the dropouts, we usually do re-examination about what the clinical symptom of the patient. If the clinical symptoms decreases and the patient appear the new clinical symptom and signs, so we usually start the oral anti-tuberculosis for the treatment. But if the oral anti-tuberculosis drop off only 1 or 2 days or 1 week or 2 weeks and patient has no decreases of clinical symptom and sign, I think it is not too new strategy and we can follow the treatment before, and we already to examine of the clinical symptom and examine the laboratory serially to make sure this not decreases of the clinical symptom. Thank you.
Thank you, Dr. Batul. Is there any something to add from you, Professor Gaitwaits?
I don't think very much, actually. I think Dr. Munir has answered that very well. I think it is a problem, though, a common problem to try and encourage people to keep taking TB drugs for 9 to 12 months. It's a problem all over the world, not just in low middle income countries. No, I have nothing else to add from what Dr. Munir has said.
Okay, thank you, Professor. Is that already clear about the
Yes.
question?
Thank you, Doctor.
Okay, thank you. Maybe one more question. Is there any? Oh, still one. Okay. The Naufal. Okay.
Thank you for the opportunity, Doctor. Good afternoon. I would like to ask to the Professor Thwaites. So actually, the Thwaites, we often use the Thwaites score in diagnosing TB meningitis in our hospital, but sometimes there are difficulties in obtaining CSF samples. So can it still be used with the with tests without CSF like the other scoring like Marais score, or it can be used if there is no CSF samples? And the second one is regarding vasculitis as a common complication. Can we use aspirin for this condition, and how long we can give the patient, or we treat the patient with giving the dexamethasone? Okay, thank you, Prof.
Thank you. Okay, so to your first question is whether or not you can diagnose TB meningitis without CSF. I mean, you can't really. I mean, of course, there'll be certain circumstances where it's very hard or impossible to do a CSF, and those might be medical. So, for example, if someone had a large space-occupying lesion in the brain that made it difficult to take safe lumbar puncture, then that might be difficult, and you'd have to rely on other indicators that they had meningitis. But otherwise, you can't make a diagnosis without doing a CSF. So in short, no, you can't use those criteria without CSF. The answer to your second question is interesting. So there have been a number of trials assessing the value of aspirin to the treatment of TB meningitis, as I think I referred to in my talk. But at the moment, there is insufficient evidence from large phase 3 trials to use aspirin for the treatment in all patients. I think we will know the answer soon, because there's quite a few trials. There's at least 3 trials going on, one in children, a couple in adults, that will define the use of aspirin. But I think at the moment, I wouldn't use it. The evidence that we have so far suggests that it's high dose aspirin, so doses of greater than 600 milligrams a day in adults, and that the mechanism by which they have an effect is by decreasing inflammation and resolving inflammation too. So, but we need those trials. So in short, I wouldn't use aspirin at the moment, and I would wait for those trials.
Thank you, Professor. Is already clear, Dr. Nova?
Yes, very clear, Doctor. Thank you, Doctor.
Is there something to add, Dr. Badru? No. Is already run out of time? Yeah. Okay, thank you, Professor. Due to our limited time, we have to end this discussion session. I would like to thank you to all speakers, and thank you for Professor Gaitwaits joining with us today and bringing us to a very insightful and interesting presentation. And thank you also for all participants and for the very active participants. So I will end this session, and thank you very much. Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih kami ucapkan kepada moderator dan narasumber.
Thank you for joining us today and for your active engagement throughout this seminar. Hadirin sekalian, para peserta Simposium Mielum XII selanjutnya adalah memasuki isoma. Kepada para peserta dapat melakukan isoma dan kami sampaikan kepada para peserta untuk dapat menikmati hidangan yang telah disediakan di luar main room atau di luar hall ballroom dan dapat bergabung kembali karena setelah ini kita akan menyaksikan sesi ilmiah selanjutnya dengan sesi migrain. Hadirin sekalian, sekali lagi kami ingatkan kepada Bapak Ibu peserta simposium hari ini, kami menyampaikan bahwa kita jangan lupa untuk mengunjungi booth yang telah disediakan di sisi depan dan sisi samping ruang Grand Ballroom, serta dapat mengunjungi booth seperti farmasi, buku, dan souvenir yang telah tersedia. Serta tidak lupa kami ingatkan untuk meminta stiker kunjungan karena pada akhir sesi bagi peserta yang mengunjungi seluruh booth akan berkesempatan mendapatkan hadiah yang menarik. Dan kami ingatkan sekali lagi bahwa rangkaian Mielum terdiri dari simposium, lomba ilmiah, ANLS, workshop USG, guided paint intervention,